afternoon. I'm Dr. Zakia. I'll be presenting our study on the safety and efficacy of double-dose Aflibercept in macular neovascularization and macular edema. These are my financial disclosures. This will be the outline. So, as we all know, Aflibercept is a 115 kilodalton VEGF trap eye protein that has high affinity for all VEGF A and B isoforms. The background of this study was mainly to reduce the injection burden on patients, and the presence of surplus medication in the injection vials was what led to the off-label trials in this condition. So coming to the objectives of our study, this was a real-world non-comparative retrospective analysis that evaluated the efficacy and safety of double dose, that is 4 mg in 0.1 ml Aflibercept in consecutive eyes with either macular neovascularization, diabetic macular edema post-retinal vein occlusion, or proliferative diabetic retinopathy. The primary objective was mainly the change in BCVA, that was post-double dose Aflibercept in the three categories, that is MNV, DME, and macular edema post-RVO, and also the rise in IOP or any intraocular inflammation for all patients that were in our study. Secondarily, we also saw the mean change in the CSFT, that is the central subfoveal thickness on OCT scans, and also the mean injection-free interval in the MNV subgroup under the PRN dosing schedule, as all patients were PRN from day one. The methodology was, we reviewed the medical records and OCT scans of all patients from January 2020 to May 24. All of them were administered by a single surgeon. Patients were evaluated for BCVA, IOP, intraocular inflammation signs were noted on the day one and the first week of postoperative, post-injection first week. The follow-up visits at 4 weekly intervals recorded the BCVA and OCT data. Injection-free interval was recorded as the time between the consecutive injections, and all patients were kept under the PRN dosing schedule since the very beginning. The inclusion criteria was all patients who gave their consent for double dose, patients with active MNB lesions or active macular edema post-DME or RVO. Patients with PDR were treated in an adjunct with PRP, and hence they were not analyzed for BCVA and CSFT changes because of the confounding factors. And all patients with neovascular glaucoma were excluded from the study. So we're coming to the results. We had 228 AIOS2025 patients, of which 140 were with MNV, 44 had DME, 30 had macular edema post-RVO, and 14 were PDR patients. So these are the baseline demographic details. Mainly, the main follow-up interval was variable in all these cases. MNV patients had a 75-week follow-up duration, the DME patients had 36 weeks, the macular edema post-RVO patients had 33 weeks, and the PDR patients had 30-week follow-up period. Coming to the MNV subgroup analysis, the patients included in that were neovascular AMD patients. 83 persons were neovascular AMD among the 140 patients, 36 were PCV, myopic CNVMs were 13 patients, and the rest were secondary CNVMs. The treatment naive and the previously treated patients were also demarcated in the neovascular AMD and PCV eyes. The 42% of the patients were treatment naive in the neovascular subcategory, and 44 patients in the PCV subgroup were treatment naive. So coming to the primary objective, the change in BCVA, we compared the baseline BCVA with the final BCVA, which was either at the end of the study duration or the last patient follow-up, whichever was longer. So the gain in the letters that was seen in the MNV subgroup, in the DME and the macular edema post-RVO subgroup was 3.75 letters, 5.85 and 8.25 letters respectively. This is a very heterogeneous group that included all previously treated and treatment naive patients. Whereas when we compared to the MNV subgroup analysis, we saw the gain in letters was 4.5 letters in the neovascular AMD, 2 letters in the PCV subgroup. The change in IOP, the IOP was compared to the postoperative day 1 IOP for analysis, and those who did not come on postoperative day 1, the IOP recording of the first week was taken, and on-table perception of light analysis were done for every patient, and loss of perception of light was followed by paracentesis if provided. Because we do not have a data on the exact number of paracentesis, the surgeon recall was sought for and was noted not to be more than 20%. So the change in IOP was not statistically significant for the DME, RVO, and PDR subgroups. In the MNV subgroup, it was significant, but both of the values were within normal limits. Intraocular inflammation was seen as any AC reaction on the first day or the first week follow-up. Keeping in mind the retrospective nature, only AC cells were sought for, and incidence of subconjunctival hemorrhage and dryness was not taken, and none of the patients presented with any intraocular inflammation. Secondary outcomes was the main injection-free interval in the MNV subgroup, which was mainly what we wanted to see. So coming to the complete subgroup analysis of the MNV, the neovascular AMD patients had a mean injection-free interval of 20.9 weeks, and PCV patients had 13.6 weeks in a follow-up duration of 77 weeks and 79 weeks respectively. But if we further noted the treatment naivety and previously treated subgroups, then we noted that the improvement in visual acuity was more in the pre-treatment naive group, which was 6.5 letters and 8.5 letters respectively, whereas the treatment-free injection-free interval was 16 weeks in the neovascular AMD and 12 weeks in the PCV subgroup. And the important thing was 52% of the patients in the neovascular AMD group and 50% of the patients in the PCV group had an injection-free interval of more than 12 weeks. So the improvement in CFFT was clinically significant in all the groups as seen. But now that discussion-wise, when we compared it to the pivotal trials for neovascular AMD, our study was taking 4 milligrams of Aflibercept in 0.1 mg, whereas the VIEW1, VIEW2 and ALTAIR studies, which were analyzed with this group, they had taken the standard dosing. They were 3 monthly injections followed by treat and extend protocol. Our patients had a PRN protocol since the very beginning. The mean follow-up interval for our patients was 77 weeks, whereas these studies had a 96-week follow-up interval. If you can see, the gain in visual acuity was lesser compared to the pivotal trials, but then when we compared on the treatment naive eyes specifically, then we could see that the gain in visual acuity was almost comparable to the pivotal trials, whereas the mean number of injections was definitely lesser compared to them. Comparing the PCV trials with the pivotal trials, the 4 mg was taken as a dosage in our case, and the others had a standard dosage. The gain in visual acuity was lesser compared to that, but when we compared the treatment naive eyes, we had a almost similar gain in visual acuity compared to the pivotal trials. Similarly for DME.
Zakia, your time.
Yes. So conclusion-wise, the BCVA for the MNV was lesser compared to pivotal trials, maybe because we had a larger number of previously treated patients. But when we compared the treatment naive eyes, they were significant. They were almost similar to what was seen in the pivotal trials. So the limitation of our study was it was retrospective, but the strength was it was a real-world analysis. And our recommendation would be that we would want a larger sample size as the control group to have a uniform follow-up duration so that we can have better insights into this. Thank you.
Thank you. May I have the next speaker?
So do you recommend this double dosing?
Ma'am, it's already available to us, and that is why we went in for this observational study as we were doing. And this is a very small sample size, but what we saw was that the gain in visual acuity was actually comparable to the pivotal trials, and also the number of injections was definitely very less, especially because we were a PRN protocol since the very beginning.
Since this was not a randomized study, what were the criteria for treating the treatment-naive patients with the double dose?
Ma'am, every patient was treated with a double dose in our institutional practice. So we did not put any patients on a standard dosage and few on double dosage. Everybody was treated on double dosage.
Okay.